Hi, it's Dr. Jenny Garrity. I'd like to welcome everyone to tonight's immunisation update for GPs. Before I go any further, I'd like to acknowledge the people of the Wiradjuri Nation and also the people of different nations on which each of our participants meet tonight. I'd like to pay respects to elders past, present and future, and to acknowledge their continuing connection to land, water, culture and community. We're committed to working in a spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health and wellbeing. I warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. And I'd also like to extend a very warm welcome to Associate Professor Nick Wood. Nick's Associate Director of the National Centre for Immunisation Research and Surveillance, and tonight he'll be giving us an update on immunisation. Thank you very much, Nick.
Thanks very much for the invitation and the introduction. So I'll just see whether hopefully you can see my screen all right. Yes?
Yes, we can.
Good.
Okay, great, thank you. We were just talking before with all the different go-to webinars, Zooms, Skype, etc. You often get a bit confused. Anyway, we're here, and I'd also like to acknowledge the traditional owners in the land on which we meet, and elders past, present, and leaders emerging. So, look, thanks very much for the invitation. It has been a particularly busy time in vaccines, as you guys at the front line have experienced in the last 2 years. The purpose of tonight is to sort of have a quick gallop through these topics and hopefully leave some time at the end for questions. The COVID story has evolved, as we all know. This is a global picture, and you can sort of see the Omicron wave, which has really been the common feature around the world since the beginning of this year. I think it's important to note that although there's a large increase in number of cases, the number of deaths hasn't really climbed as much, which is a bit of an indicator of the fact that Omicron is highly transmissible, but not as severe as the Delta or the original strain. The other issue is that now in Australia, we're really counting cases through a combination of rapid antigen and PCR testing. And as you know, that means that we may not have as good a handle, particularly as people might not upload their rapid antigen tests onto the service, New South Wales, etc. But the other key feature is that the dominant strain is now Omicron, and up until very, very recently, it was BA1 and BA2 subvariants, and then you may have seen in the news that also is changing. This graph here attempting to show the change in amino acids substitutions within the virus. On the left top there, SARS-CoV compared to flu A of different, flu H1N1, H3N2, etc. And really the point is that the SARS-CoV virus is able to change itself in a much faster way than flu does. The line you can see there between is at a more steeper angle than it is with the flu. And so that really is leading to a virus in evolution. And now you might have heard in the press about new subvariants, BA4-5 and then 2.12. And that's also, as in today's Sydney Morning Herald, there was the comment that we've now had over 11,000 people who have been infected for the second time. So that's sort of the environment that we're living in at the moment. It is confusing, and there are now a range of vaccines: community Pfizer adult, community Pfizer pediatric, Spikevax, Moderna, Nuvaxovid, which is Novavax, Vaxzevria, which is the AstraZeneca. As of April the 27th, the TAGI had recommended that the primary course is really an 8-week interval between doses. Now, the issue, I suppose, with that is that for most people, the primary course has already finished, but that was a change from ATAGI's statement last week. And the other thing that ATAGI did last week was recommend that the interval between COVID infection and your next dose of the vaccine, whatever dose that is, be a 3-month interval. So just a little bit about Nuvaxovid, which is the Novavax vaccine. It is different to the mRNA Spikevax and Pfizer vaccine. It's a protein-based, and it has this adjuvant, which is a saponin adjuvant, the bark of the saponin type tree. It's a primary course of 2 doses, now at 8-week interval. Obviously can be given to those that have had SARS-CoV-2 infection, and I'll show you in a minute the recommended schedule for different groups in the community. It can also be given as a booster dose if no other vaccine is suitable. In terms of uptake, the point really here to highlight is that we're doing pretty well with 2 doses in those over the age of 20. As we get down into the 16 to 19s, we're also doing pretty well with around about 90% uptake for 2 doses. When we get down into the 12 to 15s, it's around about 84%. And then when we drop down into the 5 to 11s, the coverage, which is sort of highlighted in that red box up there, is now around about 50% for dose 1 and 37% for dose 2. So the uptake there has not been as strong as in the older groups. Sorry, I'm just trying to move forward. This is a really nice graph, which you may or may not have seen, table, which you may or may not have seen before, and we can send the link around, but it tries to put the whole story together on one slide. And the top section is healthy people, and the bottom section is those that are immune suppressed or disability residents, aged care facilities, or Aboriginal and Torres Strait Islander. And really what you can see here is the orange is the primary course schedule, and then the first booster, which is pretty much for everyone over the age of 16, gets a booster dose, and then a winter booster, which is now over 65s, and then those, as shown down there, over 16s that are immune suppressed, and residents of aged care facilities, and also our Aboriginal and Torres Strait Islander people. So that's a sort of an attempt by ATAGI and the government to put together a schema for everyone to follow. Obviously, the game now is how best can we protect against Omicron, and the fact that majority of Australians have had their primary course, the 2-dose already done. The question is, how safe and effective are the booster doses? And it really has to be safe, number one, and it also has to be effective against Omicron, because that's really the dominant strain now. So to summarise that, what we know is that the effectiveness from the primary 2-dose schedule does wane, and this is sort of shown here. It's hard to see, but the light circles are the Omicron effectiveness, and the dark squares are the Delta effectiveness. And with 2 doses of Chadox, this was the AstraZeneca, effectiveness sort of falls by about 6 months. With 2 doses of the Pfizer vaccine, the effectiveness of the against Omicron also falls by about 6 months, and really down to quite low levels, almost at the 20% mark. So there is definite waning immunity after the first 2 doses. And this is vaccine effectiveness real-world data from the UK. When we give you a booster dose, you can see here that the effectiveness jumps right up. And the key one to look at is the open circles, which is the Omicron effectiveness, but you also get the hint that it starts to wane again with time. So unfortunately, what appears to be happening with these mRNA vaccines is they are highly effective, but the effectiveness is not lasting for a long period, and that's leading to the initial booster and then the targeted winter booster. This is the sort of summary here of against hospitalization And the key one probably to look at is the bounce up with the booster, the BioNTech, which is the BNT, that's the Pfizer booster. And then the panel to the right of that is the mRNA 1273, and that's the Moderna booster. So we do see a definite climb with the single booster. And on the basis of that many countries like the US, UK and Australia have recommended the initial booster. So that's a 2+1 for everyone over the age of 16. Now we get to the story of why we need a fourth dose and what evidence there is for that, or a second booster. And there's not many real world studies out there. Probably the best data comes from Israel. And this was a paper published, as you can see, quite recently in Nature Medicine, and it's the effectiveness of the second booster in Israel against hospitalization and death. And this is the data that sort of informed the Australians' decision to give a winter booster. And to cut to the chase, what it really showing is that against death, there is in these hazard ratios. The blue line is people that have had a winter or a second booster, and the pink line is those that have just had one booster. And you can see that there is over time a definite protection against dying, and this is during the Omicron period. So that was the reason that Australia recommended a winter booster for those who are over 65 and those over 16 who have immune suppression. At the current time, we're not recommending booster doses or a third dose for anyone at the age of 12 to 15. This is because what we know is that most of the kids who in this age bracket, if they do get COVID, which a lot have had, they're not getting too sick with it. They're also not the right age group for the PIMS-TS or the multi-inflammatory syndrome that we do see. That tends to be more in the younger kids, age 5 to 11. So the current advice is not for a booster dose for this group at this stage, although it might well change as we get more effectiveness data. In terms of what decision aids are out there, you may or may not have seen the NCIRS decision aid. It's quite useful, definitely worth a look at. It's targeted to members of the public, and basically they can go on and choose which vaccine they want to find out more about. It's tailored to the age of the person who they're interested in, and it compares the side effects of the vaccine and what's known if you do get the disease. Now, Nuvaxovid, which is the Novavax, is the newest vaccine that we are using. You or your practice may be contributing to the Ozoback safety data, and this is what this particular slide is showing. As you can see here, we haven't had a lot of Novavax doses administered and had surveys done. But what we can sort of summarize from this is that people do, on the right there, you can see the common side effects that we asked people about. They are reporting local reaction, fatigue, headache, muscle aches, and that's the green line, which is mainly after dose 2. And in the small number they've had a booster dose or a third dose, you can see that it doesn't sort of keep climbing. If anything, it drops back a bit. So people might be wondering, well, I had a nasty fatigue and headache after dose 2. What's going to happen with dose 3 or my booster dose? And this data is available to sort of show them that it's not really going to be any worse. This is the Pfizer safety data, and as you can see here, we've had a lot more experience with Pfizer. You know, in terms of dose 1, we've had 2 million surveys completed. Dose 2, nearly 1.9 million surveys, and the dose 3, nearly 1 million surveys. So we feel like we know the safety data for Pfizer pretty well. And again, the on the graph there is the common side effects. What we do know is that it's more common after dose 2 than dose 1, and what's important, again, particularly when the key name is now the booster dose, is that it doesn't appear to keep climbing after dose 2. So So, you know, if you got fatigue and headache after dose 2, you might well get the same at dose 3, but it doesn't appear to be any worse than if you, it's not like it steps up with each dose. So I think that's an important thing for people to hear about. You all know about the myocarditis story, and just to summarise this for you, the take-home messages really are that it's more common in males than females. It's more common after dose 2, and it's more common with Moderna than Pfizer. And so the rate in the males, and particularly in the males that are around about the 12 to 20 year age group, the rate is around about 1 per 10,000 doses in males with the second dose, and a little bit higher with Moderna at 1 in 5,000 with the second dose. So that is a real issue, and it's being sort of acknowledged and followed up around the world. And I'll show you a little bit in Australia what we're doing with that in a minute. So that's the other key risk. It doesn't appear that we're seeing increasing rates of myocarditis with the third dose, the booster dose. In fact, it tends to drop down again, which is quite curious why dose 2 is the key dose. But a lot of the issue here was that the interval between dose 1 and dose 2, particularly in these numbers here, was a 3-week interval. And that was part of the reason why Tagi wanted to go to an 8-week interval. And you could argue that perhaps that decision was made a little bit late, but because the third dose is given 3 or 4 months afterwards, it could well be that's why we're not seeing the myocarditis at higher rates with the booster dose. And the other thing that COVID has done has impacted potentially at a global level routine childhood vaccinations, and so there is concern at a global level about the impact this has on uptake of MMR, DTP, etc. But even locally, there is a little bit of a hint that we are seeing something, and I think it's important for you guys to see that this is coverage in children at 1, 2, and 5 years of age, and the important one to look at is the 1-year-old Indigenous, which is this one here, which I hope you can see my arrow moving, I'm not sure. But there's a trend down in the last half of last year. And we are getting the first quarter of this year very soon. But whether this is a little bit of a concern, because there's a definite divergence now between the Indigenous and non-Indigenous kids. So we need to understand exactly what is that, and ideally turn it around. And you can also see a dip down in the 2-year-old age group Indigenous kids as well. So that's a bit of a concern. So that's all I really wanted to say on COVID. Happy to take some questions later on. Of course, if one zoonotic viral infection wasn't enough, along comes another one, and obviously Japanese encephalitis is an issue out here. I was talking to Priscilla Stanley, and she said there has been some cases detected in mosquitoes out this way, as well as in a piggery and a human case. So it is an issue. Just to highlight a couple of issues that you might be wanting to hear. Cameron Webb is an entomologist at New South Wales Health Pathology, and if you like a good Twitter handle, @MozzyBites is his one, and it's quite a good one. So JE is a flavivirus, mosquito-borne. Pigs are an important amplifying host, and I'll show you in a minute the sort of life cycle. Infection is usually asymptomatic, but it can be quite severe, and I'll show you that in a second as well. So this is the life cycle. The mosquito, the Culex species of the mosquito, has interaction with the birds, the waterfowl, the migratory birds. They often then will go on and bite the pig. The pig will sort of basically allow the JE virus to replicate, the pig will then be bitten again by a mosquito and carry a larger load of virus, and then the mosquito can bite human or horse. So the pigs are an important part, and that's why the piggeries have been considered important. The other issue is that we have had a lot of water around, and that's been really conducive to the mosquitoes. The key mosquito is this one, the Culex annulirostris. It's one that is capable of spreading the JE virus. It is widespread across Australia and often likes the types of habitats that we've had encouraged recently, such as dams and wetlands. It likes to feed on a wide range of animals, including birds, pigs, and humans. But importantly, it really only goes about 12 k's from its larval habitat. This is a map of the piggeries in New South Wales that have had infection, and then we also be able to map the confirmed human cases. There have been certainly more than that now, but that's the sort of area, and it does stray up towards orange, but a little bit more down towards the sort of Griffith, Temora, Wagga, Albury, Wodonga area. The other big concern is that we have a very big feral pig population, and if pigs are an amplifier of this JE virus, then it could well be that if it gets into the feral pig population, it will be very hard to control. It's not new to some parts of the world. JE virus has been endemic in the countries as shown here. An enormous number of cases and deaths. Importantly, unfortunately, that most of them are, don't end up in severe disease, but around about 1% or slightly less can end up in this encephalitis. The peak age for onset is that 3 to 6 year age group. And so the sorts of thing, and this just shows you the incidence there in the red, where the highest incidence is in the under 9s, and then it declines with increasing age, but the seroprevalence increases, meaning that basically people in these endemic areas get exposed in the first 10 years of life and either don't have any problems and get over it, become serologically positive. Usual sorts of story of encephalitis, fever, headache, convulsions, etc. Unfortunately, if you do get the encephalitis, you have a high likelihood of having ongoing chronic issues, morbidity, and so that's a real concern for this particular infection. How do we prevent it? Well, the vector avoidance, so basically staying away from the mozzies is key. Travel, long sleeve shirts, etc., and then using mosquito repellents. The Department of Agriculture is looking at what they can do to try and interrupt the cycle, and then vaccines are an important part of that as well. As of a couple of weeks ago, we had about 37 cases of JE virus in Australia, a mixture of New South Wales, Queensland, SA and Victoria, and unfortunately 3 deaths of the JE virus. In response to this, the government has procured extra doses of the JE vaccine, and they're currently, and I'll show you in a minute who they're targeted for, but right now there's not a huge number of doses, to be honest, but they are on the way. The Communicable Diseases Network of Australia is working with the government to come up with a plan to try and manage this. The people that are at higher risk are those that are working or living close to the piggeries, people that engage in outdoor activities near the waterways. I did hear today from one of the nurses that her husband, who does work on the waterways, was unable to secure a vaccine because they were quarantining it for those that work on close near to piggeries. And then the other 2 groups are those who are travelling to JEV endemic areas or lab workers. Unfortunately, there's no specific treatment. They have tried a range of medicines, and there is no particular antiviral that works for JE virus. 2 vaccines, there's the Imajet and Gespect. And you can see in the hand, this is a table taken out of the Immunisation Handbook. The Gespect is a 2-dose schedule, and the Imagev is a 1-dose schedule. And you can see there that there is a requirement for a booster dose depending on your age and depending on which vaccine that you've got. So if you are being asked to give it, because it's not a vaccine we often routinely give unless you're in a travel clinic, probably best to have a look at the handbook again and refresh yourself that way. Imagev is a live attenuated one, so therefore we can't give it to anyone that's got immune suppression. That can also include pregnant women and breastfeeding women. The Jespect inactivator vaccine, main contraindication is anaphylaxis to a previous dose or a component of it. And there's a slide, I'll send these around via the PHN to you guys to have a look at, but the co-administration is possible with both of these vaccines, except if you're going to use yellow fever or MMR, we like you to give it at the same time, which is probably not really a concern, because in this particular environment we'd just be using it for an outbreak control. Just one slide on Q fever, just to remind you that the Australian College of Rural and Remote Medicine has an online accreditation course, which is very useful. You can have a look at that. And if you do want to be a new Q fever vaccine provider, there are some forms on the Q fever register that you can have a look at as well. So just galloping along in terms of flu, really the story here is that we haven't had any flu in the last year, and really not much at all in 2020. But 2021 is that bottom red line, and really no cases, to be honest. So that was very unusual. But the other corollary to that is that immunisation coverage for flu in 2021 had fallen, and that's probably understandable, because A, there wasn't much flu around, so there wasn't a driver to get it, and B, people were dealing with the COVID vaccine, and the access to clinics, etc., was also probably hard to do. But we know that coverage in the 5 to 14-year-olds fell from 27% to 14%, and coverage in the 6 months to 5-year-olds fell from 45% to 25%. So that was a definite drop. So what that means, I suppose, is that particularly these younger kids have not had much natural flu exposure at all in the last 2 years. In fact, a 2-year-old has probably not really seen wild flu at all. So there is that sort of no natural immunity at all in that age group, and so there will be a strong campaign to get the flu vaccine coverage up this year. I won't go through this in detail. These are all documents available in the handbook on the ATAGI. You can see there the different brands and the ages and for which it's recommended. And then also the white boxes are the ones that are free under the NIP. And I suppose in the over 65s, it's Fluad Quad, which is the recommended and funded one for the over 65s. How's the flu vaccine safety data going this year in the 2022? Have a look at Ozoback safety website. This will be updated each week. But as of the 25th of April, what's that, 10 days ago, we'd had nearly 6,000 surveys completed, and the safety profile was pretty much the same as previous years. So we're not seeing a large amount of fever. We're not seeing seeing the usual things of local reaction, but really no concerning safety features so far in the 2022 flu vaccine. I won't go into this in detail, but people ask about the co-administration of flu and the COVID vaccine. And there have been a couple of papers out there that have looked at that. This ComFlu-Cov paper, which is published in the Lancet, what they wanted to do was to see if you gave flu and COVID vaccine at the same time, did that impact your flu antibodies, your COVID antibodies, and what was the safety like? And the bottom line was that there was no impact no negative impact in terms of safety, and no negative impact in terms of COVID antibodies either. So that was all a good news story, and that's the basis for the current ATAGI advice that they can be given together. Just to highlight the API reporting, which has been a big issue in New South Wales and across the country, particularly as we roll out millions of doses in short time. You guys as healthcare providers might well have an API reported to you, and as you already do, report that onto the public health unit, who can then collect clinical information, liaise with us if necessary about any future advice on revaccination management. You guys also can go directly to us. It then all feeds into NSIMS and then off to the TGA. And if there are serious adverse events, the ministry reviews those individually, and we often have working groups involved. Just a reminder that the reporting form is available on the New South Wales Health website. This is a national TGA form which you can use to report an adverse event. Look, it's not the best form in my view. It's a fair bit of free text, which makes it harder to fill out, but it's really the way that we try and capture some of the adverse event data. If you do want to talk to NSWIS, which is where we're based, there's an email there. You can email us and we'll hopefully get back to you in the same day or the following day. We put your phone number in and we'll ring you for additional thoughts if we think that will be help, and you can also call us out of hours via that number there at the Children's Hospital at Westmead. We were receiving, late last year, around about 100 to 150 calls a day. So it was quite a busy period for us, and so we were probably not doing as well as we could in answering the phone. So we've gone to this email, and then there are 4 or 5 doctors that can man the email and hopefully answer questions for you. Myocarditis, just to say a little bit more on that. If you do happen to see a case that you think might be myocarditis, the Australian Hospitalization College of Emergency Medicine has some nice flow charts that you can follow to examine them. Just to be aware that there is, and the cardiologists, if they do, can order a cardiac MRI. I think it's to maybe the end of June for this particular indication, and it's under Medicare. So the issue, I suppose, is access to the cardiac MRI scanners is very hard to do. But when we do have a true myocarditis case, so high troponin, supportive ECG evidence, and possibly some echo abnormalities like poor ejection fraction, etc., a cardiac MRI can be quite helpful. And this is a picture of a cardiac MR, and the arrow is pointing towards the myocarditis area, which is this late gadolinium enhancement. And so that is what we can see in true cases of myocarditis. As I mentioned before, it's young males, dose 2 mRNA vaccines, and we don't really know the pathophysiology, why it happens to happen to that particular group. ATAGI does have some advice on revaccination. You can essentially, if you see a proper myocarditis, like I said before, high troponin, ECG, etc., it's really something that we should talk to the cardiologist about what's the best dose to give. There's a nice flow chart in this document, which has just recently been updated on how to manage the pericarditis. And it tells you about different breakdowns by age and by sex, etc. Because, as I mentioned, this is a 1 in 10,000 sort of event. They're not common, but they have been followed up, and so the US has followed up a group of these particular people to see how they've gone, and we are also in Australia following up our myocarditis cases as well. I suppose the good news story is that when these people were surveyed at day 90, so that's about 3 months after their event, in the blue was the people that had reporting that they had no longer any chest pain, shortness of breath, palpitations or fatigue. So the majority of people had recovered by that 90-day mark. And as you know, they usually end up either being treated with Nurofen or ibuprofen and colchicine. And they make a fairly good recovery, although the colchicine is not terribly palatable and people can end up with diarrhea, etc. But when followed up, the bulk of people have an absence of ongoing symptoms, and they certainly have importantly normal echoes, normal ECGs. But slightly worrying, there is a proportion of them that had abnormal cardiac MRIs at baseline or that are continuing to be abnormal. So that's a little bit of concern, because we don't like to see the inflammation in the heart. Obviously that leads to scarring and there's a risk of arrhythmias. So that's something that's being watched very closely. And the other thing that people are doing is looking at their quality of life. The point from this slide really is that people that have had this particular condition are reporting some anxiousness, which is probably understandable given they had inflammation of the heart and there's concern and worry about it. So that's the other outcome. Just to highlight, which you may or may not have actually seen, this is a statement from Atagi on the 22nd of April. And it's a very rare boutique thing, but it's important to be aware of. And this particularly relates to people in Australia who are of Tongan, Samoan, and Niuean, so the Western Polynesian heritage. There is a rare inherited condition in that particular group of this IFNAR, IFNAR1 deficiency. And it was actually discovered by a group of Australian and New Zealand researchers, and there's a paper that's recently been published on it. This particular IFNAR deficiency does lead to an immunodeficiency, which can lead to a nasty illness if you have the live virus like measles, etc., but also can result in a nasty adverse event if you have the MMR vaccine. Now, it's quite challenging to diagnose this disorder prior to vaccinating, so it's not overly satisfactory, but just to be aware of this particular, and it is very, very rare, so there's probably only a couple of kids every year born with it, so it's unlikely that you'll see it, but just to highlight that for you. The other point to sort of highlight also is the reminder about the catch-up vaccines. There is a free catch-up vaccines for those up to the age of 20 under the NIP catch-up, but they have to start that before the age of 20. So if you do have any adolescents that come in that you think might have missed, particularly those 18, 19-year-olds who might have missed HPV or a Boostrix or a MenACY, then that's important because they can get the free catch-up before they turn 20. Just segueing across to other topics, Meningococcal B Vaccine. So the take-home message really is it's recommended for all kids, but unfortunately not funded for all, okay? It is recommended and funded for Aboriginal and Torres Strait Islander children under the age of 2. It's Bexsero and MenACWY is funded for all ages of those that have the following conditions, health conditions, so problems with the spleen, problems with the complement, and then if they're on these monoclonal antibodies. So important to check the vaccination history, which you all do anyway, particularly those people that might have moved from South Australia, because South Australia has a routine program. In terms of Bexsero, under the age of 2, this is a bit of a reminder, and again, encourage you to have a look at the handbook to this bit of a refresher. But the number of doses that you get really depends on the age at which you start it. And so if you start it at a younger age, under the age of 5 months, you really need 3 doses if you're well. If you have medical risk conditions, then you need 3 + 1 schedule. And then over the age of 12 months, as shown here, it's a 2-dose schedule. So that's the sort of Bexsero schedule. Prophylactic Panadol can be given with each dose of Bexsero for kids under the age of 2. Can you give it at the same time? Yes, you can. So if people want Hexa and Bexsero at the same time, you can. Just be aware that Bexsero and Prevnar, you can get an injection site reaction, so best to try and avoid giving both those in the same limb. Ideally, that sort of 2.5 centimetre gap between them, you know, upper limb is obviously what we do anyway for the kids over the age of 12 months. Moving on to pneumococcal vaccine, so that's just a quick highlight for you. As part of the NIP, it's 3 doses of the 13-valent vaccine at 2, 4 and 12 months. Aboriginal and Torres Strait Islander children in those states and those that have specified medical risk conditions should get 4 doses, that's 2, 4, 6 and 12, followed by the 23-valent vaccine. So for us in New South Wales, your decision really is, does the kid in front of you have a specified medical risk condition? And that means they get an extra dose as an infant, and then they get the pneumococcal, the Pneumovax vaccine. Again, that's obviously available on air. The bottom line is that you really only need 2 lifetime doses of the Pneumovax. The next slide just talks about the pneumococcal vaccine for adults, and this looks at those Aboriginal and Torres Strait Islander people who at the age of 50 require the 13-valent plus the 2 Pneumovaxes, and healthy non-Indigenous people at the age of 70 require just a single 13-valent, and that aligns with what we do with the shingles vaccine. The previous schedule for pneumococcal, you may or may not remember, had category A and category B, and it was extraordinarily complex. So what they've done now is, and this is available at that link, is they've just outlined the risk condition, and then they've outlined whether or not they're at which age they should get the vaccine, and whether it's eligibility for the funding. So that's just a helpful table if you could, if you want to have a look at that as well. Lots and lots of resources out there for pneumococcal. And then finally, just to finish off with a little bit on zoster vaccines. As you know, there are 2 zoster vaccines which are licensed for the use beyond the age of 50. There's the live attenuated zoster vaccine, which is a single dose. And then there's the Shingrix, which is an adjuvanted, so it's recombinant, it's an inactivated vaccine. It's 2 doses given 2 to 6 months apart. Anyone from over the age of 50 is recommended that vaccine. Now, if you're over the age of 50, or if you've already had a Zostavax, you can have a Shingrix booster. And the optimal age that you get really depends on when you should get it. Really depends on their age and their immune status, and how much they want to protect themselves. So the question often is, should I get it at 52 or should I wait till I'm 70? And then the issue with getting it at 52 is that the immunity may not last as long. So, you know, there's a little bit of a trade-off here, which is why it was really put on the schedule at the age of 70. Shingrix is probably the preferred vaccine because it's got better efficacy, but it has to be privately prescribed and then therefore purchased, okay? Zostavax, just a reminder, Zostavax being live attenuated, it can only be given to immunocompetent people, so don't give it to anyone that's immune suppressed. And Zostavax is the one on the NIP from the age of 70 years. In those who are over the age of 50 and they're immune compromised, Shingrix is the one that should be used, okay? And so, you know, I think problem there is you have to pay for it. If they're mild immunocompromised, I think what I would do is there's a screening tool there that you can have a look at to see are they eligible for Zostavax or not. And you can get a localized rash afterwards. And so you just if they do have that seek, they'll often come back to you, and you can sometimes take a swab of it and have a look at it. So that was it from me. I'm happy to put a few minutes for 10 or 15 minutes for some questions. If that's all right, happy to try and answer them.
Thanks, Nick. I'll just remind all the participants that they're able to post their questions in the question box, and as they appear, I'm able to read them out on their behalf. So currently we don't have any questions sitting in the question box, but that's available on the control panel on the right-hand side of your screen.
I'd be interested to hear from the group what sort of questions you're being asked, or what are issues at the front line that you guys are facing. So we talked a bit earlier about the need for the booster dose, and one of the things I suppose is slowing the uptake in the 5 to 11-year-olds is that many of the kids have already had an infection, and therefore parents are saying, well, he's already had it, why would I give him a vaccine to protect him against something he's already had? Which sort of makes sense. However, the purpose of completing the course in those particular people is to hopefully keep your antibody up, so that if the virus does mutate and vary to a more severe form, that you've got a bit more antibody on board, so that you don't get breakthrough infection, which is nasty.
Nick, I had a patient say to me today that they'd heard about a combined influenza COVID vaccine. I was wondering if you'd heard of that.
Yeah, there are trials underway with those particular products. I think there's one starting in the Northern Hemisphere very soon, so it's a combined flu COVID, and hopefully that will be, it will work, it will be safe, and it'll be, because I don't think COVID's going to go away. As I showed you before, the virus does mutate a bit, and it'll just be either us giving you an annual booster. The issue is, unlike flu, it might not be a seasonal thing. It might just be always there in the background. But what we really need is a booster dose that gives you longer lasting protection. And it just appears at the moment that the mRNA vaccines are not really doing that.
Thanks, Nick. We've got a question from Cam Wong, and the question is the protein-based COVID vaccine a better option for people with risk of myocarditis?
Yeah, I think that probably is. Now, the caveat there is that, we've given hundreds of millions of doses of the Pfizer vaccine, and not so much the Moderna, but hundreds of millions of doses of the Pfizer vaccine around the world. So we know fairly well the risk, and as I said, as you get over the age of 30, the risk of myocarditis is very, very low. And certainly over the age of 50, it's very low again. It's just that age group in that sort of 15 to 20, 25 maybe, that is the real risk age group. So that's one thing to say. The second thing to say is that, Novavax, the protein-based vaccine, nowhere near as much experience. There were a couple of reports in the vaccine trial of myocarditis, and there have been a couple of reports in the post-licensure setting, so to the TGA after Novavax. So it's not to say it's completely absence of risk. We just haven't had as much experience with it. But I think if there were, I don't know, a 15 to 25-year-old, and certainly if they'd had an episode of chest pain, after dose 1, you wouldn't be, of myocarditis, you certainly wouldn't be giving them another mRNA vaccine. But if they're really, really worried about it and they're over 18, you could give them the protein-based, which is the Novavax vaccine. We just don't have a really good understanding of the pathophysiology, why this particular side effect happens and why it happens predominantly in young males.
Thanks,
So a
Nick.
long answer, but if they're really worried and they don't want to get an mRNA vaccine and they're over 18, then Novavax is an option, yes.
Yep. And Nick, a question from Ken Hazelton on Novavax. He asked, is there any evidence supporting Novavax as a fourth dose of being of additional benefit up to mRNA after, say, AstraZeneca mRNA?
Yeah, good question. We don't have much in the way of publications yet of such a schedule. So there is a publication called the Cov Boost study out of the UK, and it looked at mixed schedules in a trial environment, and it looked at third dose responses. If you're asking, if the person had 2 AstraZenecas, then a Pfizer, are they better to get a Novavax or a Pfizer or a Moderna as their fourth dose? That particular question, there's not much evidence to answer it, I'm afraid. So there probably is a general principle that heterologous vaccine schedules are slightly better. AstraZeneca was not as good as primary course of Pfizer, but it boosted nicely. So if you had 2 Astras and you got a Pfizer, it boosted very nicely, but it probably boosted not as well as 2 Pfizers with a Pfizer booster, if that makes sense. So to answer that specific question, are you better to have a combination of 3 or 4 vaccines? We just don't know the answer, I'm afraid. It's coming, but Novavax is listed in the ATAGI recommendation as a possible booster, but because there's no information to really inform it, they've suggested that we stick to Pfizer or Moderna as the preferred booster.
Thanks, Nick. This is a question from Scott Porter, who's from the Warrana area. And he says, we're getting a lot of Ross River fever infections at the moment. Should we be recommending Japanese encephalitis vaccine?
Yeah, it's a shame that Priscilla Stanley from Public Health not online today. I might ask her that when I see her tomorrow. I mean, it obviously shows there's mosquitoes around there. I don't have a good handle, I'm afraid, of the, piggeries, waterways, etc. out there. Probably the best person to answer it would be Public Health. Obviously, I don't know whether mosquitoes can carry both Ross River and JE. I just don't know. It's a shame. I can ask Cameron Webb that back in Sydney, but yeah, not answering it very well, I'm afraid, because I don't quite know the answer.
Yeah, and Scott just replies, thanks for that. I've got a very general question from Martin Watson. It is, what do you think are the main things that we as GPs need to do to make sure we do with regard to immunisations?
Yeah, I think obviously, well, one, in terms of when you see people, I think there's that principle which we talked about, which was HALO. So when you see someone, HALO, so HALO is their health, A is their age, lifestyle, and then occupation. So if you see someone and you go HALO and you're healthy, they're fine and healthy. So I don't need to think about extra things like meningococcal, pneumococcal. Age, they're 70. So now I've got to think about pneumococcal and shingles vaccine. Lifestyle, are they working with, mosquitoes, piggeries? Are they an abattoir worker? And that also gets to occupation. So I think that's one sort of principle that might be useful. it's very hard for you guys, amongst all the other things you have to do, to keep up with it. So I think if just flagging that there might be a desire for additional doses above the schedule or extra doses, and that would then twig you to probably either look up the handbook or go to the NCS. There's lots of resources available to help. I suppose the other thing is that it is very tricky to have conversations with those that are vaccine hesitant, there is a nice website which is called talkingaboutimmunisation.org.au. It's all one word, talking about immunisation. That's useful for members of the public to have a look at. But there's also a provider version of it. So that could be another, if you've got any spare time, have a look at that one, because it will give you some tips about how to negotiate those that are the vaccine hesitant or spectrum. So there are a couple of thoughts, but I think the Halo one's probably the easy one to remember.
Thanks, Nick. And at present, this is the last question. It is from Ari Jalal from Orange, who asks, if Shingrix is given after Zostavax as a booster dose, do we give 1 or 2 doses, and how long after Zostavax?
That's an excellent question, and I'm just trying to, you can definitely give 1 dose, and in terms of giving additional doses, I think that is recommended. I'll just see if I can pull up the proper answer for you. Here we go. I think I'm finding it. So Shingrix, where is it here? Actually not appearing there, but definitely 1 dose, and the second dose is at an interval which is of that 2 to 6 months. So yes, here we go. Shingrix is those 2 doses, like I said, at 2 to 6 month interval. And 2 doses are required even if a patient has previously received it. So I would say that at least a 6 month interval between their Zostavax and their first dose of Shingrix, and then I'd be giving a second dose of Shingrix about 6 months after that. Does that sort of answer it?
Sounds good. Yep. Thank you. So
certainly, if you've had an episode of real shingles, that also gives you a boost, and so you don't really need to have the Zoster vaccine, either Zostavax or Shingrix, for about a year after it.
Okay, thanks, Nick. And Dr. Jalal says thank you for that advice also. So Nick, I think it's about 8 o'clock now. We don't have any more questions. There were 2 things I wanted to make sure our participants remember. Their feedback is very important, and to please use their phone to scan the QR code and give that feedback. And I also wanted to thank you very much, Nick, for giving us this update. Vaccination is...
Sorry, Jenny, I just wanted to, just one thing, sorry, when I said 2 doses of Shingrix after Zostavax, I would wait 12 months from my Zostavax before I gave my first Shingrix. Does that make sense?
It does. It does.
Zostavax, wait 12 months, Shingrix dose 1, wait 6 months, give Shingrix dose 2.
Yep. Okay, 12 months gap.
12-month gap after Zostavax before Shingrix. I knew there was something in my head that was spinning around.
Thanks very much, Nick, from all of us. And I think this concludes our webinar tonight. Thank you.
Great. Thanks very much. Have a good night.
You too.
Thanks, Jenny. Thanks, Nick.
Mm-hmm.